Good afternoon, I'm Danny Mallon and I'm here to do your first installment of the GI board review, and we are specifically going to cover Hirschsprung's disease, covering a topic that is super specialized and crosses over between initial management or initial recognition by pediatricians, emergency room physicians, and then appropriate referrals to gastroenterologists and surgery. So if we are going to go over things that are very pertinent to the general pediatrician and things you might find on your board exam. I'm going to start with a case, and I want you to be honest and try your hand at trying to answer the question. But of course, there's nobody to raise their hands or be interacted with. So have fun with this, as I'm going to have fun with it too. So I'm going to read the case. It's a 3-month-old girl who visits you in the office due to concerns for blood in her stool. At baseline, she stools once every 4 to 5 days, and they're mostly yellow-brown, seedy, and unformed. She passed meconium at 24 hours after birth. She's exclusively breastfed. On exam, she's fussy and somewhat ill-appearing. Her abdomen is mildly distended but soft. Her anus is normally placed with no apparent fissures. Her digital rectal exam shows that there's no formed stool, and there's reddish-brown, guaiac-positive liquid stool that gushes as you retract your finger. Which of the following is the most appropriate step in management? A, refer to gastroenterologist. Have mother eliminate all cow's milk from her diet. C, start lactulose 5 mL by mouth daily. Or refer a patient to the emergency department. There are a couple of clues in there that in your studying for boards should suggest that you already know the right answer based on test taking skills, but I want you to commit to an answer. Good. Now we'll go over what's appropriate. So this patient in the vignette had what was concerning for Hirschsprung's enterocolitis, and there are a couple of features in that history that we'll get to in a little bit as classic presentations and some atypical presentations for Hirschsprung's disease. So what is Hirschsprung's disease? It is aganglionosis of distal segments in the intestine. The incidence is 1 to 5 to 10,000. There is a racial predominance, so it's about 1 in 7,000 Caucasians in North America. And then in selected populations that are predominantly Hispanic or African American, there's variability. In fact, there may be slightly higher incidence in African American populations. There's a 3 to 1 male predominance. It is generally a distal colonic disease. So 75% of patients are going to have it isolated to their rectum and sigmoid, and about 8% will have it in their entire colon. And then rarely, less than 1 or 2% of the time, you'll find it extending into the small intestine. So here are the things that you probably would need to know for general knowledge board exams. So on histology, there are absent enteric ganglia in the enteric plexuses, if you'll remember back to anatomy class. When you also look, you can find that there are thickened and hypertrophied nerves trying to compensate for the absence of ganglia. And then there is increased mucosal cholinesterase staining, which the cholinesterase is actually just binding to these budding neurons as they try to grow. And so that's why it's a way to see that hypertrophied nerves in a little bit better way. So here are a couple of representative images which actually can make their way onto board exams because they can be differentiated so easily. So there's a lot of words on this slide. You probably will be asked about very general things about the pathogenesis of Hirschsprung's disease if you are asked. And what I have highlighted for you in red is the buzzword of neural crest cells. The underlying pathogenesis of aganglionosis of the colon is the cessation of migration of these neural crest cells, which are the kind of derivative cells that become the enteric nervous system, and especially the ganglia that need to be present for normal bowel function. So these neural crest cells are supposed to go out from the vagal, sacral, and truncal region of the developing embryo, and then you'll also have they need to migrate, and then they actually go out and adapt to their local environment. This is regulated by genes as well as kind of other signaling, and all of this is supposed to occur properly between the 5th and 12th week of gestation. And if it doesn't, and it's arrested somewhere in there, then you'll get aganglionosis and Hirschsprung's disease. So because that signaling can come from the neural crest as well as the environment, and then there are genes that are specifically involved in that signaling, there are specific genetic abnormalities that can lead to Hirschsprung's disease. We're going to go through a couple of those. These are ripe for board questions. The associations of different syndromes as well as individual genes. I've listed some of them in a table, but the things that show up most commonly in clinical practice and hopefully most commonly on the boards would be trisomy 21, which is the most common genetic syndrome association with Hirschsprung's disease, and then some other more specific ones like Waardenburg syndrome, also called Waardenburg-Shaw syndrome. The specific gene abnormalities in that are either the endothelin receptor B or EDNRB gene, or the SOX10 gene, which is responsible for signaling and proper migration of those neural crest cells. DeGeorge syndrome, with all of its various effects on the body, including cardiovascular and immunologic, can also have Hirschsprung's disease associated with it. Multiple endocrine neoplasia types 1 and 2, because they share the RET oncogene abnormalities, can also have associated Hirschsprung's disease. And this actually accounts for about 50% of all familial cases. So when there's a family history of Hirschsprung's disease, about 50% of those familial cases will actually be mutations in the RET oncogene. So that sometimes shows up on boards. Neurofibromatosis type 1 and congenital central hypoventilation syndrome, as well as Smith-Lemli-Opitz syndromes, can also be associated with it. There's several other things that I've listed in the table, pulled from this Kenny article, but I think I've highlighted some of the most important associations. So the presentation, this is in the content specification that I was meant to address. The presentation of Hirschsprung's disease is classically the triad of delayed passage of meconium, greater than 48 hours after birth, vomiting, and abdominal distension. In all patients who have had this together in certain studies, kind of institutional series, all of them ended up having Hirschsprung's disease if they had all three of those things. But should be noted that the delayed passage of meconium is not always found, and it's only a slight majority of patients who actually have delayed passage of meconium, so it is a very insensitive historical marker of celiac disease. In the newborn period, the emesis may or may not be bilious. You can also actually present with perforation, especially of the proximal colon. In older infants, they can present with varying degrees of constipation or abnormal stooling, also abdominal distension. When they present, they may be presenting with, like the baby in our vignette that I presented you first, with enterocolitis. So the mortality of enterocolitis is somewhere around 30%, maybe ranging 20 to 50%. This is very important. This is why the correct answer in that first case was send the patient to the ER right now, because the patient is ill-appearing and has bloody gushing stool with distension that's very suspicious for enterocolitis of some sort, especially Hirschsprung's disease. Rarely you can have Hirschsprung's disease present in older ages, like older children and adults, where you'll see some atypical presentations, including chronic constipation, but that is very unusual. But you can have chronic colitis, like a pretty chronic indolent enterocolitis that's presenting, or pseudopolyps when their first colonoscopy. So how do we approach the diagnosis? This is maybe one of the most important clinical objectives that I wanted to go over with this board review. So the diagnosis is made by one or more tests. So the first test that often is done is a contrast enema. What you're looking for is a transition zone from a dilated proximal bowel to a probably normal, maybe somewhat narrowed distal bowel. And so what people will mention in a radiologic report is a rectosigmoid ratio greater than or less than 1. What you're essentially asking is the rectum bigger or smaller than the sigmoid? Because rectums normally are bigger than sigmoids. And so if your rectum to sigmoid ratio is less than 1, that means your rectum is smaller than your sigmoid, suggesting that your proximal bowel, namely your sigmoid, is larger than it should be. So this is important because you don't always see this, especially in newborns, that there's not enough dilation that has happened with kind of increased loading of the bowel with food and stuff, that you won't see the dilation in the sigmoid necessarily in newborn period. And so you'll have a false negative, meaning a normal study, in up to 20% of patients, especially in newborns. Anal rectum manometry is a newer test that is trying to fill in the gaps, trying to increase the sensitivity and specificity for those patients that you don't necessarily want to take straight to biopsy. So what it tests is the rectoanal inhibitory reflex, or RARE. If that is present, then that means that a signal has gone to the enteric nervous system and gone back to the anus and caused it to relax. What it's involved in this testing is you actually blow up a small balloon in the rectum, which then distends the rectum, sends a signal to the enteric nervous system. The enteric nervous system, including those ganglia, if present, will then send a reflex nerve signal that will cause the anus to relax. This is repeated several times during the test, and it has to meet a certain threshold of relaxation for it to be present. And when it's present, the negative predictive value is 99 to 100%. But the specificity can be lower than that, like 74 to 93%, because you can sometimes get inconclusive results. Like sometimes it relaxes all the way and sometimes it doesn't. You can have poorly cooperative patients, especially in older patients. And so you don't always get the best test, but the benefit is that it is very low risk. And when it's positive, when it's normal, your negative predictive value is super high. Now the gold standard is a rectal biopsy. So what you're usually doing is a rectal suction biopsy. And that can be done awake in infants. Usually in older kids, you want to be asleep, mostly for anxiety. And then surgeons can do a full thickness excisional biopsy, which does require anesthesia. The negative predictive value, it's the gold standard test, is 100%. If it's normal and you see ganglia, you don't have Hirschsprung's disease. The sensitivity can be lower because you may not get enough tissue, especially on the suction rectal biopsy. And it comes with significant risks. So there's a pretty significant risk of bleeding to the point of needing a transfusion or needing a surgical procedure to stop the bleeding. And so that is not to be taken lightly in these small infants, and especially if your index to suspicion may be lower. So you can get insufficient tissue. Some reports say that it's up to 30% of the time you don't get a good tissue. And you don't know what you've got until you send it to pathology. And so these are the limitations of the rectal suction biopsy. And so oftentimes, clinically, you're doing one or more of these tests until you get a pretty solid normal test to rule out Hirschsprung's disease. So let's do another case. Go along with me. A 2-month-old girl with a white forelock and anisocoria visits you in the ED due to constipation and blood in her stool. At baseline, she stools once every 4 to 5 days that are mostly yellow, brown, and seedy, and unformed. That's reminiscent of our previous case. She passed meconium 49 hours after birth. She is exclusively breastfed. On exam, she's fussy and, again, somewhat ill-appearing. Her abdomen is mildly distended and soft. And on digital rectal exam, there is, again, no formed stool. Anal tone is normal, and there's reddish-brown guaiac-positive liquid stool that gushes as you retract your finger. Which of the following is the most appropriate next step in management? You thought I was going to ask about diagnosis. No, we're moving right on to management. So what's the best thing to do next? Are you going to A, give her a glycerin suppository to help her poop? B, an emergent laparotomy? C, normal saline rectal irrigation? Or D, IV antibiotics? Commit to something. So the correct answer is IV antibiotics. This patient is sick and needs management now because that mortality in the younger ages as well as older ages, as I reported before, is about 30%. Normal saline rectal irrigation is also on the table, but you want to get that IV and antibiotics in very quickly. You'd be surprised how often you're recommending surgery on the boards as a potential answer, even though you don't actually, as a general pediatrician, perform the surgery. And a glycerin suppository is inappropriate because it's not enough right now. In fact, an emergent laparotomy is not indicated, and a laparotomy is probably going to be delayed until they can cure the enterocolitis before they take them for surgical management, which is the next piece of our objective. So what is the management of Hirschsprung disease? It's removal of the aganglionic segment with the goals of trying to maintain continence as well as promote regular bowel movements. So there have been 3 main surgical approaches to try to remove the aganglionic segment, maintain some continence, as well as keep things moving. So the Swenson procedure is very straightforward. You cut out a length of bowel and you sew what was proximal down to the distal rectum right above the dentate line of the anus. The Duhamel-Martin procedure is you leave the front half of the rectum, you take out the aganglionic segment, and then you sew to the back half of the rectum the rest of the normal bowel. Leaving a little bit of rectum helps avoid strictures, but also leaves a little bit better continence. The Soave procedure includes a mucosal and submucosal dissection, taking away the aganglionic segments, but leaving in the muscular layer, which is supposed to help with preventing leaks and other surgical benefits, but is a lot like the Swenson, where you just pull it down and sew it to the just above the dentate line. All of these things come with complication risks. So the most common risk of after surgery is obstruction. So one of that is constipation. That patients will report straining to overcome their persistently abnormally functioning anus and distal rectum. So they have to strain, or they have to push hard, or they have overflow incontinence because they have, like a typical functional constipation encopresis, where poop can collect behind their dysfunctional anus. They can also have strictures forming at the anastomotic sites that need dilation from time to time. This can also lead to abdominal distension and vomiting as symptoms, but these obstructive symptoms happen in a very sizable percentage of patients. Fecal incontinence, because they can't hold or because they have overflow fecal incontinence, is present in a very wide range according to the studies, but can be up to 80% of patients. Enterocolitis is the most feared complication following Hirschsprung's disease, and the adage that I was taught in fellowship is once a Hirschsprung's, always a Hirschsprung's, and that's because no matter what surgery you do, unless you take it all the way down to the anus, which would never result in fecal continence, they always leave a little bit of rectal stump, even if it's just like a centimeter. You are left with a dysfunctional anus that does not respond to rectal filling, and so you always have to push your poop out really hard when you have Hirschsprung's disease following surgery. And you can also have obstructive symptoms due to strictures at the anastomosis or a dysfunctional anastomosis, and so that can lead to stasis, and the stasis leads to enterocolitis, and that enterocolitis is dangerous and should not be taken lightly. So just because your patient with Hirschsprung's disease had surgery doesn't mean they're out of the woods for their complications like enterocolitis. And so when a patient presents sick after Hirschsprung's surgery, they're to be managed very carefully with early initiation of rectal irrigations to decompress the bowel. Involve their surgeon early and often, and don't hesitate to start antibiotics if you suspect enterocolitis. That's all I have for you. I hope you learned a lot about Hirschsprung's disease, and you're going to get all the questions about it on the boards correct. Good luck.